Thanks very much, Virginia. I'd like to start by acknowledging the traditional owners of the land, the Wurundjeri people of the Kulin Nation, and to pay my respects to their elders past, present and emerging. And also, as I make that acknowledgement of country, I'm reminded of the fact that Aboriginal Australians have a life expectancy which is about 10 years shorter than non-Aboriginal Australians. So when you hear those acknowledgements of country, you must remember that we're not only acknowledging the country on which we stand, but acknowledging the difference in the health status and the life expectancy of Aboriginal people. So I'm going to try and do a couple of things in this presentation. First of all, to talk a bit about the work at Grattan. We've done a number of reports on issues of hospital safety, quality of care, which I think are probably relevant to this audience. And the three reports we've done over the last 12 months look at various aspects of safety, including the costs of unsafe care. I'm also going to talk briefly about a report I did for the Victorian Government targeting zero. So just to first of all set a bit of a context. So the Australian economy in the period up to about 2004 grew much faster on average than it has since that period. And of course, in the context of slower growth, we have to be careful about how spending in the health sector is growing. And what this graph shows is that if you look at the darker bars are later periods, 2009-10, the lighter bars are earlier periods, and you can see that the darker bars are more or less always higher than the lighter bars. That is, real spending on health is increasing over time. And the second thing you can see is that for the older ages, 80 plus especially, the rate of growth is much steeper. That is, health costs of the older people, not standardised for the number of older people. This is each person over 80, for example, is going up much faster than younger people. So when we talk about the ageing of the population, there are two effects that we need to be thinking about. The first is the number of older people are going up, but that's not so important as it turns out. What's more important is what we're doing to those older people is quite different from what we used to do to those older people. To give you an example, anaesthetics have improved over the last couple of decades, and so we're more likely to operate on a person who's over 80 than we used to be. This means that we're more likely to give a hip replacement to a person over 80 than we used to. So then you say, oh, isn't it terrible that health expenditure is going up? Well, as it turns out, I live in the city of Melbourne. I live within walking distance of Vic Market. I go to Vic Market every Saturday, roughly. And for example, I might want to look at tomatoes. And I might want to buy Russian black tomatoes, and I pay something different for Russian black than I might do for stewing tomatoes. Now, as an economist, I can keep two concepts in my mind at the same time: quality and price. Politicians can't always keep two concepts in their mind at the same time, so they might emphasise just that cost is going up and not think, hang on, aren't benefits going up at the same time? That is, isn't the fact that an older person is able to have a hip replacement who wasn't able to have a hip replacement in the past and is able to live without pain, isn't that a good thing that may be worth paying for? Anyway, so as I said, this is per person. The other interesting thing, the heavy black line here is how gross domestic product has gone up, and the bars are different types of expenditure. This is all expenditure by governments, Commonwealth and state. And what you can see here is that hospital expenditure is going up a lot and a lot faster than gross domestic product. And so too to primary care, so to private health insurance. And so this means that hospitals are taking up a larger proportion of the Australian economy. Government spending on hospitals are taking up a larger proportion of the economy than they used to, which of course is putting pressure on state government budgets. It's also putting pressure on the Commonwealth government budget, and private health insurance is also doing the same. So these things are, I might add, that the growth in hospital expenditure is the fastest growing area of any area of government spending. So it's obviously an area of concern that we have to think about how might we save money without actually throwing the baby out with the bathwater. So I said that growth in the number of older people isn't as important as the growth in what we spend per older person. And, whoops, the red is not an arrow thinger. But the light bar at the, so what we've tried to do here is explain how has health expenditure changed over the decade 2003 to 2013. So the light bit at the bottom is, well, there's been population growth, so there's been an increase in spending. Then there's been population ageing, that is the changed composition, and that's the orange bit. Health inflation has gone up faster than CPI, that's the darker bit. And then basically the major change that's happened is we're doing things differently. More services, improved services, new services. Now, not all of those are worthwhile, but a lot of them are, and that's what's driving growth. And trying to change that, as I said, is difficult, but there are also benefits associated with that change in composition. Australia isn't the only place that's had an increase in spending, and more or less every country, as you increase the size of the economy, as the country becomes wealthier, then we decide to spend more on health. And so one of the things we like to do with more money, aside from going on holidays in France, which I like to do, one of the things we like to do with our money when we've got more money as a nation is to spend it on healthcare, because we think we might get a benefit from it, and in fact sometimes we do. So what we see here on the left-hand side is life expectancy, and you see from 1880 to 1970, life expectancy at age 65 more or less didn't change. That the dramatic change in life expectancy that happened over that period was driven by reductions in infant mortality, death rates at younger ages. And so where there wasn't much of an increase in life expectancy for people aged 65. Then since 1970, there's been an increase in life expectancy for people over at age 65, but it's only been about 8 or 10 years. It's not been as dramatic as people think, because when they say, oh, the population life expectancy is now 85 and it used to be 65, well, when you look at it for people at 65, it hasn't as been dramatic as you think. And a lot of the change in life expectancy, some of it has been years lived free of disability, some of it has been years lived with a non-severe disability, but some of it, a significant proportion, has been years lived with a disability. So although we're living longer, we're also living, some of that extra is years lived with a disability, which again makes the whole issue of what we're doing with health spending a bit complex. Now, what this slide shows is what's happened, is the benefits of this spending. And there's a sort of, you can classify mortality into two broad categories, one of which is avoidable mortality. That is the mortality rate which might be influenced or influenceable by good prevention or good health care. And what we see here is I've got the 2011 mortality on the left-hand side of each bar, of each group, and the 2016 mortality on the right-hand side. And this is only avoidable mortality, that is mortality which can be affected by prevention or healthcare. And you'll see if we look at Victoria or New South Wales or Australia, if we just look at Australia, you can see that the mortality rate per 100,000 population avoidable mortality rate per 100,000 population was around 400 in 2011 for Australia as a whole, and dropped to about 350 or so for Australia as a whole in 2016. So a significant drop in avoidable mortality, which suggests we're doing something right in the healthcare system. What's also interesting in that is I've separated out the avoidable mortality rate in metropolitan areas and the avoidable mortality rate in outside metropolitan areas in each state. And what you can see is outside each state, the avoidable mortality is about 10 or 20% higher than the avoidable mortality in the metropolitan areas of the state. Now, there seems to me, is it acceptable in 2018 or 2016, when these data are, that people in rural Victoria have a 10 to 20% higher chance of death, mortality rate, than people in Melbourne? When, if you think about it, a lot of these things are preventable. This is mortality which can be influenced by public health interventions and healthcare interventions. Cancer screening, for example, smoking and other interventions, for example. What's interesting is the mortality rate in metropolitan Melbourne, for example, in 2011 was lower in 2011 than the mortality rate for rural Victorians in 2016. So the rural Victorians are at least 5 years behind in terms of where mortality rate is. So that there's a lot of room for improvement. And in fact, Victorian rural mortality is a bit higher than many of the other states, which is also a surprise. So, despite the fact that healthcare expenditure has been growing a lot over the past few years, governments are projecting it's going to go down over the next few years. Whether this is true or not, who knows? But again, the driver of increased spending is all about non-demographic growth. That is not accounted for. It's change in services. So again, it raises the question, what are we going to do about it? And one of the issues is we've got to worry about, is the healthcare system going to be overwhelmed by the boomers? Well, maybe not. Maybe that's not going to be the case. And we need to think about ways of making the health system more efficient. And one of the ways of making the health system more efficient is to improve quality, which I'll attempt to show you now. So there are a number of ways of measuring the quality of care, one of which is so-called sentinel events, operating on the wrong body part, for example. And they're very, very rare, only occurring in 0.0012% of all admissions. Another way of measuring it is what the Australian Commission on Safety and Quality in Healthcare called hospital-acquired complications, or HACs, and they occur a little bit more frequently, 2% of all admissions, 5% of multi-day admissions. These data are for both public and private hospitals, by the way. Another way of measuring is to say all complications, whether or not something went wrong, just whether something went wrong. And that's much more frequent, 11% or 20% of multi-day. So rather than focusing on the big problems, governments have tended to focus on the small problems for some reason. The list of HACs, the hospital-acquired complications, the Commission on Safety and Quality of Healthcare, who developed the list, said these aren't all preventable, but you should think about them. The government, when they came to endorse the list, said these are preventable. But of course, governments, ministers of health and premiers and prime ministers are omniscient, so you can understand why they knew better than the Commission on Safety and Quality in making that decision. So, what's interesting from an insurer's point of view is that the indemnity risk applies to all complications, not whether someone has decided to designate them as preventable or not. So the focus at the moment is often on focusing on what I call the old paradigm is to say harm is rare. Sentinel events, 0.0012%, about 100 or so of those are counted in the way they count sentinel events in Australia at the moment. And I think we need to contrast that with a new paradigm which says, well, actually, there's more frequent than you think, 27% of all multi-day stays, for example. So we shouldn't be thinking, and our mindset shouldn't be that complications are so rare that we have time to analyse every one of them. Rather, we should be saying, complications are frequent. What can we do to reduce the incidence? So we know that there are some hospitals which have a lower rate of complications than other hospitals, whether or not they're labelled as preventable. So we've got what is happening is there's a paradigm shift occurring and both sorts of language are present. So some people will talk about preventability, even though it's a concept that really, if you think about it, has no meaning. So if you think about it, something that is seen as preventable today might not have been seen as preventable 20 years ago. The best example being central line associated bloodstream infections, where 20 years ago people said, oh, that's just one of the things that happens, whereas now they'd say this is preventable. Similarly, what might be seen as preventable at the Royal Melbourne Hospital may not be seen as preventable at Hamilton Hospital or Alice Springs Hospital. So it's time-based, it's location-based. So it's really probably not a terribly useful term anyway. And of course, the two different paradigms have different ways of counting. We know of harm in one paradigm through incident reports. In another, we can actually analyse the epidemiology of outcomes, look at all of the data, for example, and so on. So there are different ways of thinking about complications, and often you as insurers only hear about things because they're incidents and you hear about them, but if you're thinking about prevention, you've got to think not only the ones you hear about, but the ones you don't hear about, because next year some of the ones you wouldn't have heard about, you will hear about, and so it's in your interest to think about prevention as a whole. So insurance pays for one side of them, but you might need to think about them in terms of prevention in the new paradigm as well. So if you think about incidents, we often say the way to deal with incidents is to analyse them, to try and understand the root causes, and so we undertake root cause analyses to try and understand what went wrong. So this is a study which was done in Victoria, which analysed all the root cause analyses that were done in Victoria, and they classified the recommendations in these root cause analyses to whether they were strong recommendations, which meant that the recommendations were likely to prevent a reoccurrence of that sort of complication, whether they were moderate or whether they were weak. And you can see that about half of all the recommendations were judged as weak by these independent assessors, very often making recommendations about training and education, very often making recommendations about new procedures and new policies, which are seen as weak because there's no forcing function in them. So even though we say let's analyse all these incidents, when we actually do analyse these incidents in a quite expensive process, it turns out that we actually may as well have not done that because we've only got weak recommendations coming out of it. This is a pretty busy slide, but basically what it shows is these are the weaknesses, the potential problems when developing root cause analysis recommendations. There are things like the analysis may end when most convenient root cause is found, not all one that fits the investigator's biases, not the underlying one. There's quite an interesting PhD thesis done at Queensland University of Technology a few years ago, which found that by and large, if there was a difficult issue with an individual, they often didn't talk about it in the root cause analysis. And the other recommendation, the other problems go there. You don't have to read them all, but all I'm trying to say to you is that root cause analyses don't fix all the problems. So when I was talking about this paradigm shift, there's been a shift over time. So initially, safety was seen as secret doctor's business, and that the way to make sure that it worked was to have to make sure that it was kept a secret doctor's business. You had qualified privilege and those sorts of things to stop the courts hearing about it. And that typically the focus was identifying the bad apples. Over time, we replaced that paradigm with safety as a systems issue, trying to have an appropriate fault or a just culture approach, trying to have systems and so on, government agencies starting to measure. Then we started to have the debate about safety as a public issue. Should we open up to the public and tell the public what the rates of complications are, what the rates of mortality are, and so on in different hospitals, public and private? And then we started, and this is hitting Australia as we speak, so we know we have public reporting nationally for public hospitals of hospital-acquired infection rates of particular kinds. We don't have national reporting of complication rates or mortality yet. And then moving on, we've moved on to a situation where safety is a payer issue, especially in the United States, but also in Australia, where we talk about financial penalties on public and private hospitals, for that matter, for higher rates of complications. And we've talked a bit about that in our most recent report. So this is a survey done by my colleagues at the University of Melbourne, where they asked all of Victorian hospital board members, and there are lots of hospital board members in Victoria because we have lots of separate hospitals. They asked them, what was the quality of care like in your hospital compared to all other hospitals in Victoria? And the good news is that 75% of board members said the quality of care in their hospital was better or much better than average. And a further 20%, this is the dark red numbers, a further 20% said it was about the same as average. So 95% of hospitals in Victoria are providing average or above average care. This is great news. It's also great news for my consultancy company, which teaches arithmetic to hospital board members, because I've obviously got a significant marketing opportunity here. I've called it the Lake Wobegon effect because it's after a famous American radio program by a guy called Garrison Keillor called Tales from Lake Wobegon, where in Lake Wobegon all the children were above average. Well, it's the same with Victorian hospitals. It's also got an academic basis called the Kruger-Dunning effect. Anyway, so public reporting. This slide and the next slide show a meta-analysis of the effect of public reporting, and by and large, if it's on the left-hand side, the score, it meant that study showed that public reporting led to or was associated with improvements in outcome, and this was same facility. The first few are same facilities, different period. The next one is different facilities during the same period. By and large, shows a reduction in mortality rate or whatever the indicator was that they used for measuring quality. And this one looks at different sorts of diseases. So basically, by and large, we know that public reporting seems to work. It may not work because consumers use the public reports. It may work because hospitals are shamed into doing something about it when they see the public reports. So I said there are a number of different ways of measuring complications. As I said right at the start, about 11% or so of all admissions have a complication. If you got rid of all of the hospital-acquired complications, the designated HACs, you'd reduce that 10.7 rate to about 10.3, a very, very small reduction. But if you reduce the rates of all complications to the rates seen in the best 10% of hospitals, you'd see a substantial reduction in complications. And that would mean that about 250,000 people would leave hospital without a complication every year, which of course would reduce costs. So what I've done in this slide is actually to calculate the costs of what a complication costs. So if you go into hospital for a transplant and you have a complication of the transplant, the additional cost to the hospital, these data are public hospital data, the additional cost to the hospital is about $26,000 per case. Now, there's not many of those that have complications, but you can see that some complications add a lot of money to the cost of treating those patients. Now, of course, these complications are not very frequent. They're rare. But what's more interesting, I think, is this list, which said, we're not only going to focus on those complications which are expensive, we're going to look at all complications. And again, this is public hospital data. But all in this year, 2014-15, complications cost the health system, not able to be saved, cost the public health system in Australia about $4.6 billion in that year. Hospital-acquired infections alone cost the public hospital system almost $1 billion. Now, not all hospital-acquired complications are on the list of preventable complications, and maybe we should be looking at reducing all infections, not just those that are on the list. But you can see that the complications add up in terms of expenditure. These are frequent, less dramatic, but they cost a lot of money, which means in turn you can think about having a business case for quality, and there's a picture of a business case. What we've got here is each of these orange dots is a public hospital. Now, because of the way public hospitals are funded in this country, the hospital gets rewarded for having more complications. I know it sounds a bit strange, but that's how it works. And you don't get rewarded for every complication. But so what we did was we calculated how much extra revenue those 20 public hospitals got for having complications, taking into account each individual patient. And then we calculated how much it cost them to have those complications, the complications they did in those 20 public hospitals. And what you can see, this line here, whoops, not that line there. Basically, if you drew a line 45 degrees from the centre there, the origin, everything below the line, the costs are greater than the revenue. Everything above the line, the revenue is greater than the cost. There are no hospitals which actually made money from complications. In fact, on average, the cost of complications were 2 or 3 times the revenue they got. So hospitals already have a financial incentive, and an important financial incentive, to actually reduce their complications, a financial incentive. The trouble is, none of those 20 hospitals would know what the costs were or what the revenue was. No individual hospital would have done that analysis. And so we're suggesting it might be a useful idea to tell the hospitals what their costs are and what the implications are, so that they can do something about it. This is another analysis we did. We looked at hip replacements, and we looked at 3 hospitals. In Victoria, we're very innovative with our names of hospitals. We call them Hospital A, B and C. Or that might have been because we weren't allowed to identify individual hospitals in the data set we got. But what we did was we look at the complication rates, and you can see the Hospital A has a much lower complication rate than the other 2 hospitals. This is after taking into account the complications or the complexity of the patients that actually came into the hospital. And so taking into account the complexity, Hospital A is a better place to go than Hospital B or C. Hospital C is definitely where you don't want to go. But what's interesting about Hospital B is that it's good for people under 74, but not good for people over 75 and over. Now, it might be because it doesn't have a very good geriatric service. We can't tell from our data why these differences occur. All we can see is what occurs. So what we argued here is that we ought to tell hospitals, the hospitals ought to have more information so they can understand what their complications are, and they can understand where they need to look to try and improve complications. We also suggest the public ought to know which one's Hospital A and which one's Hospital C, so that we can see a bit more pressure on the hospitals. So this one is, each dot here is again a public hospital, and we looked at just admissions for medical cardiology, and we standardised for the complexity of the patients again, and then we said, how efficient is the hospital? And the vertical axis is how efficient they are, essentially, whether they are more than what's called the national efficient price in terms of their cost of care, or below the national efficient price. And the horizontal axis is their complication rate, effectively. It's their risk of complications, taking into account the patients, so on. And what you can see is there's no relationship between how efficient they are, or how much they spend on their medical cardiology patients, and the rate of complications. So when people say, oh, you know, we can't, you know, being a good hospital actually costs money, well, that's not true. The hospitals in the bottom left-hand corner are both more efficient than the average and have better outcomes than the average. And so if you want to do something about it, you've got to look at you have different strategies for different issues. On the top right-hand corner, you've got the hospitals which are both expensive and poor quality. So I'm not entirely sure what the strategy is there, but it might involve inviting the CEO to look for other places to work, or it might involve actually trying to understand how it is that they end up there. You could also have hospitals which have got money to spare, they're more efficient than the average, so they can pull themselves up by their bootstraps. Who knows what you do in that quadrant. But even in this best quadrant, there's improvement that can occur. So there is a hospital which is the best hospital, and you can try and move all hospitals towards that position. So I'm reminded of when I used to be associated with the Alfred, we had the doctors of the Alfred used to go duck shooting every year, and I should give you a warning, this involves duck shooting, so if you don't like duck shooting, please leave or cover your ears. But so in Victoria, you're allowed to shoot red-tailed ducks and not allowed, sorry, you're allowed to shoot green-tailed ducks but not allowed to shoot red-tailed ducks. And so they were sitting there in the hide, and the general practitioner looked up and said, I think they're red-tailed ducks, and turned to a second opinion to the physician. And the physician looked at it and pondered for a long time, as physicians tend to do. And the radiologist says, but look at the bone structure, I think they're green-tailed ducks. And the psychiatrist said, no, no, look at the family formation, I think they're red-tailed ducks. And the surgeon went, kapow! And turned to the pathologist and said, make sure that's a green-tailed duck. Anyway, that's not how quality assurance works anymore. So what we need to do is to actually set an ambition. Rather than setting the ambition that governments have, which only reduces the number of complications trivially, we need to set a much greater ambition to actually improve the rate of all complications, and one which starts from where every hospital is. So we need to be specific to the hospital. What are the complications in your hospital that we need to address? How are we going to improve it in your hospital? So we need to give information to the hospital, and we need to give them the tools and the resources so the hospital and the clinicians can actually work to improve. So that is what I just said. We need to publish information about relative performance, so they're, I won't say named and shamed, but so the public can have confidence about what's happening and that we're serious about this. And indemnity insurers, for example, might reward hospitals who reduce their overall complication rates as part of a longer-term preventive strategy. Thank you very much, and I've got some time for questions.